Okay. So good morning, everybody. Thanks for joining us today. We'll wait for a few minutes until we get some more folks coming in. We have about 18 of you this time. Last time we were just right at 50. So we're gonna hang on for a few minutes and then get started. So welcome. Good morning, Buffy. Okay, I'm thinking that we'll go ahead and get started. Good morning. My name is Al Hassan. I'm the clinic administrator for the New Life Clinic. I want to welcome everybody to today's session of Addiction 2021, Treating the Whole Person. This is hosted by SafeRx Mendocino Opioid Safety Coalition. The SafeRx Mendocino Coalition members are medical professionals, educators, law enforcement, community-based organizations. And we're taking a community approach on preventing and reducing opioid misuse and stigma, promoting holistic, comprehensive treatment for a healthier community, free from opioid misuse. If you're interested in joining, go ahead and please chat in the, post your name and your email address into the chat, and we can go ahead and include you on any of the announcements that are coming out. We also have a web page that's www.saferxmendocino.com, and I think one of my coworkers will go ahead and put that in the chat so everybody can see that. You can also find us on Facebook and Instagram and Twitter, things that I know very, very little about. So in terms of a few housekeeping items, if you have any questions on how to receive your continuing education credits, you can privately chat one of our moderators, including myself or Grace Peeler or Buffy. Please mute yourself during your presentations. If you don't, we'll probably catch you and we'll go ahead and mute. I know that many of you are at work and you got a lot of things going on, and we appreciate you taking the time out of your busy days, certainly to be here. Additionally, we're going to record the session so that people who didn't have an opportunity to be on during the live session will have an opportunity to observe it at a later time. There's going to be an evaluation link at the chat box at the end of the session. hey, take a look at it. Let us know how we did. Let us know what you'd like more of, what you'd like less of. We really do want to hear from you, because we want to, moving forward, we want to be able to improve on our efforts and meet the needs of the community. So again, your feedback is also a requirement, though, for obtaining CEs and CEUs. And so you complete the feedback, we send you a certificate at your CE certificate, as well as a certificate of attendance in case you need that. We have a really, really good lineup today of local presenters. I'll introduce them now, but I do want to recognize the groups that put this together. Adventist Health, representatives from Telewell, Mendonoma Health Alliance, the New Life Clinic, Mendocino County Public Health, the McCaven Care and Prevention Network, and SafeRx Mendocino. A lot of people put some significant time and effort into bringing this to you, and we hope that you appreciate that and find our contributions here valuable. We're going to go through a little bit of housekeeping items, and then we're going to show a video on stigma that Buffy and the team put together and did such a wonderful job on doing this. It just, when I see it, I can't help but sort of getting choked up in many ways to see the efforts that are being put forth towards reducing stigma in our community and allowing our community members to come forward to get assistance without being judged. Our first speaker today is Katie Bell. She's board certified in addiction nursing. She's been doing this for a while. She's currently a MAT training and technical assistance specialist for Telewell Indian Health project under DHCS. She also works for the UCLA Integrated Substance Abuse Tribal Echo Clinic, and with the Center for Care Innovations, addiction treatment starts here. She worked for the Betty Ford Center, and interestingly enough, Katie and I crossed paths in 2001 in implementing buprenorphine at the Betty Ford Center, which really changed how they did work there. Katie learned about treating opioid use disorder with buprenorphine on the NIDA Clinical Trials Network. Katie's passionate about developing best MAT practices and certainly understanding, gaining a better understanding of the root causes of addiction, such as trauma, ending stigma, and she's first and always, a patient advocate. So I'm going to go ahead and I'm going to show our video here, and then I'm going to turn it over to Katie. And then after that, I'll introduce our second speaker, Dr. Libby Guthrie. So let me advance the slides here a little bit. This is our agenda for today. It's a pretty full agenda. Katie's going to present on a stigma survey, and then she's going to present on stigma and injury. We'll have some time for Q&A, and then Dr. Guthrie will be moving in to present as well. So again, some of the housekeeping items. I already went through those, so there's no need to belabor the point there. And I think at this point, what I want to be able to do is to show you the video. All right, here we go.
We are in Northern California and beautiful here, and we have dealt with the same thing that everyone else is dealing with: racism, health inequities. Homelessness is high, people are out of jobs, and substance abuse is really affecting our entire community.
Studies have shown that approximately 60% of addiction is genetic predisposition. So there are many triggering factors that can lead to addiction. People suffer from depression, or simply people suffer from other psychiatric disorder, put them at a higher risk for addiction. Prescribed opioid medication is another gateway, and of course, environment can also be a factor.
Isolation is a big part of addiction here. This community is, a lot of us are like spread out, and they use alcohol and other drugs to cope.
I became addicted to opioids after having spinal surgery, and I started taking medication as a result for the pain, and was addicted to them in total for a year and a half. I thought stopping the drugs would be easy once I decided I was going to, and I was having physical reactions that I could see and feel when I wasn't getting the drugs. So it was harder than I thought.
By the time I was 12 or 13, I was smoking meth with my mom, and I was using every day after that, and it was really hard to imagine having a day without being high. And I went through several different foster homes my last year and a half of high school, and the last home I was in were foster parents who were a little bit hippie, rock and roll, and without their unflinching love, especially in the light of my most awful behavior, I honestly think that I may have killed myself, either accidentally or otherwise. My life today is such an incredible miracle, and it is never lost on me. I'm in my 27th year of recovery, and there are still some days where I stand at my kitchen window and I look outside my backyard and I'm struck with disbelief that I live in a safe home with my sons who are safe, who have everything they need, who have never seen me loaded. My life is incredible.
Many people experiencing addiction do not seek help because they feel shame about their addiction, and they're concerned about being judged by their friends and their family or the general community. So it really, stigma surrounding addiction and it being their fault prevents them from getting the help that they need.
Oftentimes, stigma becomes the barrier. So if we want to see a successful outcome, we have to start from there. Our role here in our community is really to educate everybody more about what is addiction. We need to let people know that the earlier that we can start the intervention, the better outcome that we are going to see.
Freshman year, high school, I got caught smoking marijuana on campus by our favorite teachers. That was pretty shameful. I got expelled from the school, so I went into depression. I got back into school, played sports, but I still drank, I still smoked, and then I think eventually I used meth. One night I overdosed, that really took me really by surprise. It really woke me up to realize that I could have lost my life, and it really helped me realize that I need to stop abusing myself. My body, my spirit was telling me that I have a bigger purpose to serve. To be able to recover here in my own community at home was the best thing, because it really opened my eyes to what the true meaning of being a community member, being a family member, being a friend, being a husband really means. The life I live today is amazing. I'm thankful to be able to experience fatherhood, be able to experience being married for almost 12 years. My mind and my heart is open. I feel connected to recovery that's possible.
If you're a loved one of somebody who's struggling with addiction, I think one of the first steps to do is reach out. Let that person know that they're loved and cared for, and let them know that you're not going to judge them for the choices they've made in their path. When someone is ready to ask for help, there are definitely resources in our area. With Mendonoma Helplines, we can help you get connected to those services. It can be online, it can be in person. We're here to help. If you're a person experiencing addiction, I want you to know that you're not alone. Mendonoma Helplines is more than ready to help you find the resources to jump those obstacles that are in front of you.
Addiction is not a choice and it doesn't define people.
Como hablamos de las personas que usan drogas, importa.
I am not my addiction.
We can overcome addiction
Together.
Wow, that's so powerful. You know, I just have to I have to commend those individuals who had the courage to share their life experience to make this video possible. I mean, that took a lot of courage for them to do that, and I think they're in many ways going to pave the way for other individuals to seek help moving forward. So wonderful job with that, and you know, Buffy and the team at the Safe RX Coalition did a tremendous job there. Thank you all. At this point in time, I'm going to go ahead and turn it over to Katie Bell. Katie.
Thanks, Al. Hi, everyone. Can everybody hear me? See me? So the very first thing that I want to direct you to is to the chat box. Libby just put it up again. It is a Survey Monkey of an anonymous stigma survey. It's 10 questions. This is not for scoring. This is a self-reflective tool. So please head into chat and open that up. I'm going to pull a copy of this up on the screen so we can look at it together also. So let's get started with the Survey Monkey self-assessment. I'm going to pull it up here, share. Okay. Has everybody been able to find it and get started on this very quickly? This is a way of exploring our own perspectives and biases. We'll take just a few minutes. All right. So finish up the survey. Is somebody in the chat box able to collect that data? I'm going to pull up my slide set. Okay, so hopefully everyone has had a chance to take a look at those questions in the stigma survey and maybe get a sense of ways that we each need to make a change around how we express stigma. That video is just so beautiful, so moving. I saw it last week too, and it touched me even deeper this time. But one of the providers that was talking on that said, stigma becomes the barrier. So I'm going to have nothing to disclose. And we did our stigma survey, and Buffy and her team are turning that into data. So if people are interested, they can reach out to find more. If you want a copy of that stigma survey, we'll be happy to get that to you. So our learning objectives are going to be around a whole person care, common terms that convey stigma, and the new terms that can convey dignity. We're going to cover, first I wanted to kind of just jump in and talk about what whole person care for substance use patients in primary care looks like. How do we divide up the care? We get grants to build programs, and primary care teams have figured out how to do best practice wraparound care. So we have medical, behavioral health, recovery support, and case management. The medical involves, of course, a waivered provider. They can prescribe buprenorphine, Suboxone. They will do the medical admission if we're entering a MAT program. Then the primary care needs are met often by the same provider, but maybe not always. And they will do the new patient appointments. If somebody knocks on one of our primary care doors and they want MAT care, we're going to get them enrolled as a new patient. And also non-providers can prescribe buprenorphine for pain management for patients without opiate use disorder diagnosis. And then an RN, I'm an RN, so we can do a lot of the care management, follow-up care, buprenorphine initiations, all those things that supports the capacity of a waivered provider. So that's medical. Behavioral health. Every new MAT patient should receive a complete behavioral health assessment within the first month so that licensed behavioral health person can do some of the diagnostics and the referrals for medication if needed, county behavioral health for moderate to severe needs, and evaluating the patient's interests in supportive therapy, skill-based support, or other interventions for early recovery. Often a patient is not ready or interested in the deep work, the hard work of therapy, but their assessment is complete in terms of their early needs. Recovery support, our KDAC counselors, they're essential. This is where the rubber hits the road for our patients when they get that one-on-one, that group support. And the substance use counselors in our MAT programs handle a lot of the case management or share in them. They're just invaluable in terms of early MAT care. And the case management is kind of everybody's job. If you have a good care coordinator, they're going to know everybody in the community that can help their patients get their needs met. So the ACEs Aware calls this a network of care. They call it a trauma and resilience informed network of care. And these are the systems that we intersect with on behalf of our patients. And if we're especially lucky, we have a bridge hospital and clinic in our community and referrals to higher levels of care when needed. So, oops, that wasn't what I wanted to do. Can you see my screen? No.
I think you might have to reshare, Katie.
Okay.
There we go.
Oh, you know, we say when this happens, we say, okay, boomer.
Yes.
So anyway, this is the picture that we often wrap around our program development, our care development, and our primary care. Often there's only 2 or 3 of us that are doing all of this work, and we have to really collaborate. So I'm going to shift now to the other topic, which is of course part of everything. Stigma is the biggest barrier ending the opioid epidemic. It's shaped by our thinking, the bias of and perception. People who use substances are bad and immoral rather than suffering a chronic condition. In our clinics, we're doing a whole lot of really addressing that misperception, and the shift has been pretty extraordinary, but we still have far to go. Stigma is communicated by words, language, tone, attitude. Indifference to a person's well-being is also a way that stigma is expressed. Indifference from the politicians that make laws and the policies is also a way that stigma is expressed. And stigma becomes internalized by the person seeking help And we just talked about that a little bit in the video. And this fuels the shame of stigma. And what happens is that our patients don't find their way to our door early enough or even soon enough to thrive and survive. Common feelings. So where does stigma come from? We talk about stigma, but often it comes from real feelings. Just about every one of us has had a very direct experience with addiction or alcohol use disorder. And we understand there is a lot of pain around the struggle that we see in our families or in our communities. Anger and frustration drives stigma. If you have somebody at your front desk who's struggling with a family member and they just may be angry about all addiction. Fear is, you know, are they going to make it? Are people going to make it? Hopelessness and grief. Influences such as 12-step cultural and religious rules, sin and moral failing. So the perception that if they only tried harder or if they were a good person, they wouldn't have a substance problem. This is projected through many cultural avenues and religious avenues. And behaviors and consequences can be difficult and destructive. So we have feelings inside of us about substance use that can be translated into a tone and indifference and attitude that we direct towards our patients. Understanding trauma as a common root cause of addiction. The question is not why the addiction, but why the pain. The source of pain is always and invariably to be found in a person's lived experience, beginning with childhood. One of my favorite teachers out there on trauma and addiction, Gabor Mate, really speaks very directly to this. We have adverse childhood experiences, adult trauma related to lifestyle of drug and alcohol use. And people, when we think about trauma, sometimes it becomes a almost an obscure jargon term. But the most important thing about trauma is to understand that people with trauma need to feel safe, and they need to establish trusting relationships. So this is a crucial aspect of care for those of us that are meeting with our patients. And also to remember, where there's trauma, there's resilience, which is a very important key to all of this perspective of substance use, trauma, and then resilience. And so why opioids? Why would somebody reach for an opioid? Opioids, this is crucial in terms of the connection between trauma and full agonist opioids. Opioids change the perception of pain. This includes numbing all pain. And people with untreated trauma can self-treat. I don't like to use the word self-medicate, but we self-treat our pain with opioids because it really can numb the entire experience of trauma. So stigma injury is something that I've been looking at for more than 20 years, and I decided to give it a name because I was very aware that we were talking about it and beginning to understand, and I was talking about it with my patients, and how do you treat it? What do you do? So imagine what it is like for a person who has suffered from a severe substance use disorder for decades when they encounter stigma at every door of care. Secondary injury has occurred from the seeking of help, a stigma wounding or injury. So think about that secondary wounding that has occurred. So and this is a little more on the wounding, on the injury, what it looks like. Due to experiencing repeated stigma in settings designated for care, a person will not seek help And that was discussed in the anti-stigma video, or even basic medical or dental care. So not just help for their disease, but for help for their primary care needs, their medical needs, and their dental needs. Symptoms can be fear of emergency departments, distrust entirely of medical providers, and feelings of shame and dishonesty. I often have sat with patients who have asked me, begged me not to make them go to the ER. This was in the before times, before we had Bridge in California, but the emergency room was a common vector of stigma, and the change is significant, but it's still occurring. If not treated, the person will continuously internalize the shame and not seek care. So this is a real wound. How to treat. The way that I started treating this was really talking about it and allowing patients to understand that this was not just their perception and a form of self-loathing, but that this was something that they had been experiencing for a while. Humility expressed by medical providers and care teams is a balm to the stigma injury. So when we partner with our patients and we talk about this, I always just go, well, let's work together to make a change here. Language of dignity begins with listening, followed with respect. And we'll talk about that a little more. And develop trauma-informed care, understand that stigma itself is traumatizing for people seeking help. For some, it has been decades of disrespect, harsh judgments, and minimal care. So staying focused on the person, that human being who is before us, ready to make some kind of change in a healthy direction, and bring compassionate, respectful interventions. One of my favorite interventions when I begin treating a patient is to let them know that the door will always be open, no matter what happens, that they will be able to come to my door and ask for help. Confirming that at the beginning of the building of the relationship is very helpful. And we partner with our patients. We abandon paternalistic rules and instructions, and we build a trusting relationship and support autonomy. Autonomy is the engine that drives change. So we really need to honor it and nurture it and include a person's autonomy in every intervention. And the door will always be open to you. It's a beautiful way to start a relationship. Stigma in its many forms, real briefly, it's institutional and structural, political will and funding for treating substance use disorders. The congressional allocation of funds was an extremely slow response. But the money is coming now, and we're building programs, and we're going to need more. Medical care settings, contempt and decreased care time for medical providers in emergency and hospital settings. As I said earlier, this is changing, but we have a ways to go also. I used to have to go with my patients to the emergency department in order to get them to get care and advocate for them. Law enforcement and justice system, don't get us started. Jail without drug and alcohol treatment, withdrawal management can be old school and unkind. In the past 2 years, there's been an increase of jails providing buprenorphine care and continuing buprenorphine programs if they're enrolled in one. And it's a good thing, but we're just getting started. So just a few phrases we don't use. Substance abuse, that word abuse was identified as the only diagnosis which had the word. So we now use misuse or use, but I'm going to refer you to the Substance Abuse Mental Health Services Agency in the federal level in their title is the word abuse. So maybe someday there'll be a change for SAMHSA. We no longer use the word addict. This is one of the most common titles that we have attached to people. A person with substance use disorder, people who inject drugs, people who use drugs is the appropriate way of referring to people who use drugs. An addict, term addict, for example, if I was in an NA meeting and I said, I'm Katie and I am an addict, that's part of the culture and we're not here to change the culture. So that term is still used as a way of kind of identifying that I'm here to make a change in the 12-step setting. Drug seeking can be reframed as relief seeking. We've often heard that term in many medical settings, primary care and hospital and ERs, ED settings. So reframing that concept and that term to relief seeking, focus on the person rather than the behavior. This is a really important shift for those of us in the medical profession who may still be using that term drug seeking. Needle exchange, we now call them syringe exchange. This is an essential aspect of harm reduction. Beautifully and powerfully done. Very rarely do we hear needle exchange very quickly. Harm reduction folks are a powerful force of compassion and change. We use people first language in many things. People with diabetes, person with schizophrenia, people who use drugs, person with alcohol use disorder, people experiencing homelessness is another. We're all working on this and we don't need to correct each other. We can correct ourselves and model the language of dignity. I just wanted to point out real briefly that street language and even clinical language, street language, a specific approach to cultivating dignity is to avoid common street terms. And we all know what they are for alcohol and drug use, but to also not correct clinic staff or our patients. We will hear a lot of stigmatizing terms, and our job is to effectively use and model the language of dignity. Those of us working in addictions are also part of the recovery culture, can rethink whether using street language to bond with our patients is a really good idea, and does using street language subtly and not so subtly reinforce stigma. So I put that before you for consideration. And also, over clinical, too much clinical language with our patients is also maybe not the best way to some of the concepts of recovery and care in MAT programs. I'm going to give you an example. Usually this is a little tiny bit controversial. The cage aid screen was validated many years ago. It's used as a routine screen. So let's see what it looks like. Have you ever felt that you ought to cut down on your drinking or drug use? That's the C. Have people annoyed you by criticizing your drinking or drug use? That's the A. Have you ever felt bad or guilty, for G, about your drinking or drug use? And E is eye opener. Have you had a drink or used drugs first thing in the morning to steady your nerves or to get rid of a hangover? So that's what a cage aid screen is, still used very commonly. The E, eye opener, is actually bar talk from the 60s, which was when this screen was built. So whenever I have the opportunity to maybe use another screening or recommend another screening, I don't recommend cage aid. I know if I was the patient, I would answer no to all of these. So just, we need to look at everything with fresh eyes when we look at stigma, when we look at health equity. There's many things we need to keep our eyes fresh. Urine drug screens, we would never call any lab result, any A1C or any other lab result clean or dirty. And a urine drug screen is a lab result. We would say positive or negative and be specific, positive for opioids, positive for methamphetamine, for example. So it's still, you still hear it. I still hear clean and dirty almost every day in the world of substance use, but we're getting so much better. So think about it as a lab result. Quick case study. So Al's going to read a quick case study, and we're going to start thinking about this patient. And after we read the case, write in the chat if you're interested, if you want to participate, the signs of stigma injury in this patient, the stigma in language, tone, and care, if any, and what care was missed because of stigma. So I'll way, and then we're going to move into put in your answers, put in your thoughts. There's 3 questions here. Signs of stigma injury, stigma in language, tone, and care, if any, and what care was missed because of stigma. And just, we're going to be looking at all your answers after we read this. And then we're going to move into some Q&A.
Thank you, Katie. Okay, so Allie's a 19-year-old woman presenting to the emergency department in her small hospital in a rural community with complaints of a severe earache. Allie has hesitated for days to seek help as she overheard a staff member refer to her as the addict in Bay 3 at her last visit there. This is the only hospital in her small town, and she has been coming here for emergency care most of her life. Recently, she has had more visits, including treatment for a heroin overdose about 6 months ago. As she is brought to her bay in the emergency department, she hears someone on the staff refer to her as a frequent flyer.
Oh, sorry.
That's okay.
Okay, boomer.
You're testing me there, right? Okay.
Yeah, I wish.
As the new RN reviews her chart and her current symptoms, she sees a recent positive test for pregnancy and asks if she is still shooting drugs. The wait for the MD to see her is long, and she is beginning to feel the onset of opioid withdrawal. The lab results return, and when the MD comes in, he begins with CPS, Child Protective Services, will take your baby if you don't get clean. Your drug screen is dirty today. Now, why are you here today? The MD prescribes antibiotics for ear infection and refers her to a follow-up with her primary care.
Thank you, Al. So I don't have access to the chat right now. I'm going to have to fiddle with that, but start putting in your thoughts. Where do you see signs of the stigma injury in the person? Where do you see stigma expressed in the care, and what was missed? I'm going to pull this, make this. No.
So here, Katie, I'll go ahead and
Okay.
share some of those in the chat.
Alrighty, thank you.
Let's see. So if I can find my chat, here we go.
Okay.
So referring to the young lady as a frequent flyer, so automatically, that's one of the issues. Let's see, something's going on with my chat. Here we go. Stigma was occurring before they even went into the hospital. Mike Spears says, yeah, no doubt. I mean, she was probably reluctant to go in. Referring to the addict in Bay 3, asking her if she's still shooting drugs. Her referring to her drug screen as dirty. Wow, these are great coming in. Addict and frequent flyer. Everything about what the MD said to the patient was stigma, telling, certainly from telling her that CPS is going to take the baby away if you don't get clean, your drug screen is dirty. What are you here for today? Why are you here for? The long wait to see the doc. Buffy says, yeah, as well. CPS will take your baby away if you don't get clean. So there's Kate, it seems like there's a lot of things.
Yeah, I'm actually able to see them too. Thanks for reading those. Also, I love that the person who said everything about what the MD said to the patient and no referral to treatment. So let's look at what was missed, because that's the decrease in care that we see so often.
Another good one we had was not examining her earache or asking about it at all, which is what brought her to the ER in the first place.
So we would almost expect her to leave without receiving care.
Right.
Which is really, really common without even getting that antibiotic that she came in for, right?
Yep.
So just real briefly, is this is a composite of really just 2 patients. So, and there's a lot in here. I kind of built it so that we could really think about things that are done very casually without thought in our settings. And I know they're still going on. So any thoughts on this being accurate in your world of treating addiction? Anybody? Okay. Sadly, too much. Yeah. So we're on a mission to change the subtleties of stigma, which come through all things, and to understand that our patients have been wounded by stigma, because guess what? We have a chronic progressive relapsing disease in front of us. And if for the first 2 decades of seeking care, they've had to walk in and feel shame or be shamed, that's going to really change their choices next time when looking for care. So my thing is, there's no wrong door, and let's make sure there's a welcome mat right in front of that door, or a welcome sign right on that door. So I'm almost done. Here are some resources for case management. I talked about the network of care, and that ACEs has developed. This is brilliant. SAMHSA with that A stands for abuse. There's another abuse there, but they still have they have a really excellent comprehensive case management tip book that came out recently that's really, really worth spending some time with. And I guess there's something else at the SAMHSA store that I think you should go find. So references and links, we heard, those of us that were lucky to hear Dr. Herring last week, the Bridge to Treatment. Medication Assisted Recovery Anonymous is one of the most beautiful 12-step programs I've ever encountered. And it's because of the pandemic, it's been made available to many, many more people. So if your patients are looking for a good 12-step program, while on buprenorphine or other medications for their mental health and their addictions, this is highly recommended. It's called Mara International. And then here's some of the references for my talk. So can you see me?
Yes, we can.
So how are we doing with time? Any questions or or thoughts. If people want to unmute and just speak up, you don't have to do it through anything that really jumped out at you that you wanted to talk about more. We have a few minutes to do that, right, Al?
Yes, we do.
I wanted to ask, this is Debbie, Katie. I wanted to ask if you're going to have a list of those links somewhere that I can get them after this webinar is over.
Yes, I think everything that we're doing in the summit's going to be available afterwards.
Okay,
Right,
perfect.
Grace?
Yeah.
Thank you.
Yeah.
Yes, and we also have, there are sessions being recorded, but yeah, we'll probably after the whole series is over, we'll send out a big push with all the slides,
cool.
and everybody. Yeah.
Thank you.
Anyone else have something?
Hey, Katie, you mentioned creating autonomy. And I'm wondering, what are some of the things that you do to help develop or enhance an individual's autonomy who's come to see you?
Oh, I love that question. So that's the goal. That's the engine, is autonomy. And so first of all, is to value it. The clinician will value the autonomy. Autonomy, and to me, healthy recovery is healthy autonomy. So autonomy is being able to make choices. So if we go, this is what you have to do or else, we've not offered any autonomy. So offering choices every step of the way, understanding that person's pacing, that's, people need time to think about things, to think about changes, to think about their choices, to always keep healthy choice in all the interventional conversations, and I call them conversations because often that's what they are. It's driven by that understanding of open-ended questions, of motivational interviewing, meeting that person where their autonomy is, what are your goals? And maybe the goal for today is to get enough Suboxone to make it through the day. And if we're sitting there where our goal is to get them into residential treatment, we're never going to meet. So autonomy is really taking the time to listen and support, understand goals, understand that choice is important. People need time to think about things, and to understand that this person, we don't save people. We give information and support, and we support autonomy, and people go out and save themselves. So there's a lot to say about autonomy, but I think you begin by really valuing it. It has great value.
Thank you, Katie.
Do you have any
other
thoughts?
questions?
No, go
Oh,
ahead.
I'm sorry. Go ahead, Katie.
Do you have any thoughts on that, Al, about autonomy that you wanted to add?
You know, I think that it was a huge step for our profession to begin to value autonomy and the right for people to be able to make their own decisions based upon the options that are available. And I think that for years, our profession has said, you do it this way, or there's the highway.
Right.
And that there's only one way to do it. And the reality is that there's more than one way to do it. And the timing and the options are for the individual to choose.
Yeah, thank you. And I'm also very interested in pace. Every person, every human being has a pace in the way that they think, the way they consider it. So when I'm with a patient, I actually imagine that I'm walking with them to find their pace. But that's the art of motivational interviewing.
Yeah.
You never stop learning. That's the beauty of it. Any other questions or thoughts out there or comments? I hope this was valuable, but I just want to say one thing about giving stigma wounding a name. When I worked at the VA, there was a term that began to enter the conversation about care for combat vets, and it was called moral injury. And in the early days that I was there, it was at the periphery of conversations about treating our combat vets. And by the time I left the VA, it was a central part of the care and the diagnosis. And I learned that when we name something and we begin to see it, then we begin to do something about it. And I think we talk about stigma very often from a top-down perspective or from the perspective of a provider. And I really want us all to look at how stigma impacts the life of the human being.
Could I make a comment?
Of course, Tim.
Both that and your comment, Katie. From a provider perspective, I don't think it's this or the highway, Al. I think this is what we have available for you. And in our county, there's a limited range of things that are available. And then the provider is dealing with a sense of urgency. And your anecdote was a good example of that. There's concern about that baby, and it's an urgent concern, and people don't feel like we have time to wait around and understand the pace and everything because of that. So, it puts a provider who wants to help and could even be respectful and, in a bind when there's very few options for helping the person who is very wary of getting help as well. So I'm just saying from the perspective of a provider.
Yeah, Tim, Katie,
Can I say something?
Well, Katie, do you want to go ahead and comment on what Tim had said?
I hear you loud and clear. That is a very clear perspective, and thank you for that. And I think that as we understand that there's different ways to address the urgency of that baby, because you're absolutely right. I think that's where we're beginning to shift into other ways of approach. And in a bridge hospital, you have a substance use navigator who's going to do a lot of those interventions that the provider can't do in terms of treating the mother-baby patients there.
Mm-hmm.
Thank you, Tim.
Thank you, Katie. And Tim, you're right. There is that sense of urgency. And what I was talking about is do it this way or the highway. I think that's how our profession used to be. I think we're changing and recognizing the autonomy that an individual has, and as Katie mentioned, their pacing. So I completely get what you're talking about in terms of fewer options, reduced options, and the urgency in terms of looking out both for the care of the individual and their baby. We have time for one more question. Haley, you had your hand up.
Haley?
Haley, you there? Okay, Terry had a comment then. And then we're gonna go ahead and move on to Dr. Libby. Terry? Or maybe it was Andrea. Andrea, go ahead.
Well, I just put my hand up, but I did want to say in regards to that previous comment that, I mean, technically the urgency for the baby is really mostly by the time the mom delivers, because the withdrawal syndrome is the biggest threat. There's other threats, but they're less common. And so I feel like part of the frustration is you look at the end goal, and you feel how far away that is. And providers get really frustrated by that. But, you've been talking about how just opening the door and listening and lowering that patient's fear of seeking care is like the first step. And that's always possible. And, I've had a lot more success with myself in not getting frustrated when I see patients like drop out of treatment and come back and drop out of treatment and come back and then come back and stay. you know? And so like, if I'm looking at the end goal, I get worked up about it. But if I just think about like step by step by step, then, you know, and have faith that things might ultimately work out, then it's less, you know, I feel like that there's still hope.
Thank you.
Thank you.
Beautiful.
Katie, go ahead. Yeah. Andrea,
Okay,
I think
Al.
you described most of us.
Yeah, thank you.
I do. Yes, I think you described us to a T. So I want to thank you all for that. Katie, again, it's always good to hear from you. I really appreciate your perspective, and truly you are a patient advocate. Thank you very much.
Thank you.
So moving forward, Libby, so Dr. Guthrie has a master's degree in clinical psychology, a doctor in education, a doctor of education in counseling psychology. She has extensive experience in the field of HIV service provision, hepatitis C education, prevention, and care coordination. She specializes in harm reduction, case management, CBT, and narrative therapy, along with specialty work for persons with co-occurring disorders and persons with serious mental illness. And so without any further delay, I'm going to go ahead and turn it over to Dr. Guthrie.
Thank you. I need to make a disclaimer right off the bat so that I won't be as nervous. I have really bad allergies right now, and I have a tendency to start to cough uncontrollably. If that happens, Grace will continue through the slides as I mutter at her through my coughs. Hopefully that will not happen, but we're going to try.
Yeah.
So
I gotta pull up a different. There.
Okay.
From beginning, and now we're gonna share. Okay. Oh.
I can just read off these. Okay.
We're gonna get through this. Okay. Here we go. Okay. All right.
Oh, that was just.
And we're just gonna go from here, and there we are.
All righty.
Move this little thingy for you.
Thank you.
Okay, so
okay, move it forward. So I wanted to start with just the basics. Uh-oh.
People with mental
It's the recording.
No.
Okay. You want to just read off the slides then?
Oh, this is awful, you guys. Do you have my original one?
Yeah. Give us 1 second. We're just, you know, having some technical fun over here.
Yeah, last night I tried to just record it in case, but I stopped after about 5 minutes.
And you think, okay, this is the one. This is
so the one you're going to see is slightly different than the one I'm using.
That's okay. Everything's fine.
Okay, everything's fine.
Okay, hopefully this doesn't have, now I'm just gonna share.
That's fine, start there, that's fine.
Okay, and now we're gonna do this.
Sorry to waste people's time.
Thanks all, we're here. Okay,
It's all good.
Oh, alrighty.
All right, just start.
There.
Yes. Okay, we're going to start over, and hopefully there's not a voiceover in the background. So people with mental illness are actually far more likely to experience a substance use disorder than those that are not affected by mental illness. Here in Mendocino County in our caseload, and Tim's on, and he may have real absolute statistics on this, but the caseload at McCavan is often up to 80% of our severely mentally ill also have a substantial substance use disorder on board. According to SAMHSA's 2018 National Survey on Drug Use and Health, approximately 9.2 million adults in the United States experience co-occurring disorders. And I imagine that that is wrong, and that it is it exceeds that number, probably double. There's no real specific combinations of mental and substance use disorders that uniquely define co-occurring, but these are some of the most common mental health disorders that are seen. Anxiety and mood disorders, which I believe Katie mentioned is often the precursor of the use of opiates and alcohol, and anything that's going to calm that nervous system and make the day seem brighter. Schizophrenia, we see a lot of methamphetamine use in schizophrenia, which is interesting. Not sure what I have to say other than anecdotal information about that, but schizophrenia often the co-occurring is methamphetamine use. Bipolar disorder, so in the extremes, when the depression is very, very severe on that end of the spectrum, the person may be using stimulants to try to bring them out of that state, to raise them to a space where they can even get up out of the bed and brush their teeth. And when they're in the manic phase, sometimes, believe it or not, they will also use methamphetamine, but the mania itself, as many of you I'm sure have seen, can be so disorganized and people literally running amok. Major depressive disorder, like that in bipolar disorder, you've got severe and debilitating depression, and you're going to have methamphetamine use quite consistently, but as again, Katie had mentioned, if you want to numb pain, you're going to take whatever that is that you can find at that moment to do so. And then post-traumatic stress disorder, and I would say that easily 60 to 70% of our clients at McCavan do have post-traumatic stress disorder on top of multiple other disorders. In PTSD and anxiety disorders, we have the fight or flight response to danger, but in PTSD, it continues beyond the immediate threat, causes the person to restrict his or her life down to very, very manageable pieces, and it can easily develop into a disorder. Again, the mood disorders, major depression, dysthymia, and bipolar disorders are very, very regularly seen in our caseload. And the caseload that the providers in our county see through specialty mental health services are severe, those that have an eligibility that is reached a medical necessity because of their severe mental illness. It can be based on the duration of the mental illness, the functional problems that come from that mental illness, and just simply the life of the individual and how severely it's disrupted by that mental illness. We see folks with short attention spans, difficulty concentrating for extended periods of time and sometimes for just minutes. Disorganization in major life activities, so very, very little structure in their daily activities. However, people, especially homeless folks, can really, really schedule out their days in a really productive way in order to be able to access services and care when people are around and can help them. They have poor problem-solving skills and planning abilities, poor response to confrontation and stressful situations, impaired social functioning. So easily triggered. And if you've also got a borderline personality disorder on board, which again, a very high percentage of our clients have, It is very, very easy to trigger anger, and the anger response and firing case managers, and I'm never coming back here again, I'm going to go somewhere else where they treat me better, and all of those things that come with borderline personality disorder. And the psychosocial functioning is worsened because you have the presence of these other disorders, and you may have other comorbid conditions as well. It's very complicated to make a definitive diagnosis with people who are just entering through your door, and you are required to do an assessment on them. If you don't know much about them, to do a differential diagnosis and figure out which comes first is a major effort. I know that back in historical times, 10 and 15 years ago, it was as soon as somebody walked through the door that had a substance use disorder on board, they would just be sent away, if you will, from mental health services. And conversely, people who came in with severe substance use disorders, if they couldn't be handled by a treatment facility, so people would get shuffled around from place to place. And we're hoping that things are changing in that area, which I'll discuss in a minute or two. In the US, over half the adults with drug use disorder also have a co-occurring mental health disorder. Again, that's a statistic, but I actually, anecdotally, I think that our staff here and many of the people that are working in Mendocino County in behavioral health well understand, and in substance use treatment, well understand that this is probably underreported. Yes. These are some of the other substances that are on board. So when we talk about polysubstance use, every one of these might be on board with a person who's got mental illness and they're drinking alcohol from time to time, and they smoke daily. They sometimes use opioids, sometimes stimulants. Marijuana's a regular day-to-day use. Hallucinogens, maybe not so much, but if they come that person's way, they're going to be used. And prescription drugs. And trauma has been discussed, but the high prevalence of trauma in individuals that have co-occurring disorders really requires clinicians to, before they even start the assessment, consider the possibility that there is trauma history. It's highly likely. It can obviously include early childhood, physical, sexual, or emotional abuse, experiences of rape or interpersonal violence as an adult. And I want to say that so many of our clients come to us with these kind of trauma histories, but particularly women who are living out on the streets can experience these rape, assault, all sorts of issues which present the need for using methamphetamine and other stimulants to stay awake during the night so they're not assaulted. And then they may sleep during the day, either helped by some kind of a downer or simply because they're exhausted from staying up so long. And it's always a good approach to be sensitive to the likelihood that the client has suffered at least one, if not multiple, previous traumatic experiences. And it is going to interfere with the ability to trust. And like Katie said, going into see a medical provider in an ER or even in a primary care office that treats you consistently in a way that that doesn't recognize your humanity, but only recognizes your substance use, can really reinforce that consistent feeling that you're being re-traumatized, that you're not valued as a human unless you get clean someday and do all the right things. And it can be so detrimental and so damaging to helping that person have a sense of trust in you as a provider. I just wanted to say this little bit about the justice system because so many of our clients cycle through the local jail. They go to prison, they get out of prison, they come back, but the local jail at any given time is probably 50% people who are suffering from co-occurring disorders. And we just have a habit of every morning and afternoon checking the booking log because we figure that that our folks are going to be there. If we can't find them, that's the first place we look. Very high rate of victimization for these people when they're in custody. They often experience more use of force by correctional staff, again, because the mental health issues are on board. They're feeding the substance use. The substance use is feeding it's a cycle, and it's ongoing, and we need to find ways to break that cycle. Go ahead. Thank you. Integrated treatments are really the most highly recommended. For example, given the worst outcomes that could be associated with treating anxiety and substance use disorders in isolation or separately, clients can really benefit from an integrated approach. Given the bidirectional relationship between the two conditions, addressing them both simultaneously is actually the most efficacious way to go. Go ahead. People that have co-occurring disorders and don't have other disabilities as well have a slightly easier time than people that have them and have other deficits, educational deficits, any kind of stabilization, deficits in thinking and processing information. And it often takes a lot more effort and a lot more treatment of both conditions to help that person attain and maintain abstinence. They need to learn, they have additional challenges that require learning more diverse skills, and they often need more support. If you have somebody who is bipolar and then they're in treatment in a treatment center that is only addressing their substance use, you're going to have all kinds of problems present themselves during that treatment. And it's best to have someone on board that is able to actually address the mental health challenges and try to tailor the skills that that person learns beyond relapse prevention, but also thought stopping or other CBT, cognitive behavioral techniques or other things are even more important. Although our county doesn't really have a wholly integrated substance use and mental health treatment provider, so we don't have a all under one roof, everybody talks together, everybody works together in a team, we have started some collaborations that make me feel very hopeful. Even so much as I don't know how many years back, Tim, 3 or 4 years back when we started talking about behavioral health, therapists and rehab specialists addressing the use of the substances as part of the treatment plan, instead of having to work around using that language about substance use as one of the complicating factors. And it just, it was so time consuming and exhausting to try to manage a treatment plan that didn't really talk about substance use. And I'm imagining in the substance use disorder field, treatment field, that it's pretty much the same. What are the barriers for this person to be able to get through the treatment program? There are often mental health issues. So one of the things that I always try to do when I'm doing an assessment is to do a screening for acuity, do some very common screening that I'm sure a lot of you know. Katie mentioned the CAGE aid, which is not one that I regularly use, but there's the Beck Anxiety Inventory, clinical opiate withdrawal scale, substance use screening tools, mood disorder questionnaires. So there's a variety of things that if you put them all together, you can figure out what your most appropriate first step, if you will, is. And so the quadrants of care has been established for about 20 years or so. I first learned about it through SAMHSA quite a while ago, but it's a very useful tool when you're seeing somebody to figure out, if you will, which quadrant that they will be falling into at the time that you're meeting with them to start a treatment. Quadrant 1 is less severe substance use and less severe mental health. We might see those people in our exchange who come and go, and they're functioning and they're working and they are managing their lives fairly well. Quadrant 2, more serious mental health disorder, but less severe substance use disorder. So they may be getting help for their mental health at any number of providers in the community. The ones that we encounter the most would be in quadrant 3, more serious substance use disorder and less severe mental health disorder. And quadrant 4, we are packed to the gills with folks that fall into this area: severe mental health disorder and severe substance use disorder. And those really need to be taken into consideration during every meeting, every session. How can we manage these pieces? And what would be the most beneficial in our county at this time is if we really were working collaboratively and acting as though we are under one roof, even though we aren't. That we had free access to Mendocino County substance use treatment. We talked with the counselors there on a regular basis about our clients. They could call us at any time. We worked on their treatment plans together. We knew what all the moving pieces were, and we knew who was in that area of treatment. It's a great tool to use, especially if you do have a treatment team that maybe doesn't just meet once a month, but talks to one another daily to help their clients manage substance use treatment and their mental health treatment, and really coordinate those efforts on a consistent basis. So that's what I'm talking about, stopping the silo-focused service provision, which, although we talk about integrated care and we talk about collaborations, I still feel that there's a resistance, if you will, to sharing our professional, our expertise, and being a team that shares that expertise, and not feeling like somebody has to own that client or own their treatment or what have you. The other way to deal with that is cross-training your workforce. I'm sorry, okay, is cross-training your workforce, making sure they know how to use screening tools that are outside of their professional focus, so they can at least say, hey, I need to call so-and-so about this, and maybe we can get an ROI and we can start collaborating on treatment for this person. Complex case conferencing, but again, almost a daily or a couple of times a week, let's say, a real check-in about what are you doing and what are you doing, until we actually have services that are completely integrated. Consistently reassessing the needs of the client and figuring out what the focal point is at that moment. Is it more a substance use issue that's in the way right now, or is it severe mental illness that's really not they're not medicated yet, or they just can't get out of this cycle that consistently leads them back to using medications and substances that will make them fear. Harm reduction case management is sort of you know, it's kind of the paradigm that we work under in our agency. You don't deny recovery services because people aren't ready for abstinence. We start very far down the end of the continuum of care. And that says that if you walk through our door, we're going to offer you unconditional positive regard, and we're going to talk to you about what you need right now. And when we're going to talk to you in the future about small steps that you might be able to take to attain the things that you need right now and in the near future. Never denying help, because we have an idea of what real recovery is and is not. And it doesn't matter if you're working in harm reduction, you may still hold those beliefs, but they're not beliefs that you should be sharing with your patients or clients because they're not helpful. You know, you may say, oh, I know they could do it. I know they could do it. They have to come to a place where they feel they can do it. And that's when they're really going to dig in and start looking at whether substances are really something that they want to rely on for comfort the rest of their life, or are the detrimental aspects of that comfort so intense that I'm now ready to move forward. And there's absolutely no shaming, not ever. They've already had this in abundance. Katie mentioned this as well, that people have already been shamed in places of business and hospitals and doctors' offices and the library, and wherever they go, there's some kind of discrimination, particularly if their issues are obvious. And they don't need any more of that. Uh-oh.
Something here.
Oh, this might be such an old one that it doesn't have. Excuse me, folks. I may have to go on to my paper.
I think it's ended.
Oh, Lord, I'm so sorry.
Well, she's going to keep on going.
I'm going to keep on going.
We're going.
Just see my face droning on and on and on. So also in harm reduction focused case management, the development of boundaries and expectations of respectful behavior are bidirectional. We're going to be respectful, we're going to behave well, and we ask our clients to do the same. We celebrate any positive change that they experience, that they're proud of. We don't care how small that is. Notice moments that others haven't noticed. Notice little changes. Notice things that you need to say to that person. Wow, what a great job. You know, great work. How did you feel about that? Or nothing, just great work. use motivational interviewing consistently to balance benefits and costs associated with their use or just the behaviors that they display. Constantly be kind of asking, once you've established yourself with a client, not on first, not an entry, but is to say, yeah, how are you feeling about that 2-month goal you have, or that 3-month or 6-month or year goal that you have? Do you feel like you're getting there? What are some of the boundaries you keep coming across as you're trying to meet that goal? And I'm bottom line kind of a narrative therapist. So one of the big deals, or one of the things I like to do with clients is to help them change their overarching narrative. The narrative of I'm a loser, I can't do anything, I've been abused my whole life, I'm never going to get that housing, they're never going to like me, and shift the narrative into a place of, well, you made it here. You made it to 43 years of age. It's just shifting and looking with a positive light on that person's survival skills, their ingenuity, their resiliency, and helping them see that part of themselves on a consistent basis, so that they start to shift their own narrative from chaos to quest, to I can do more, I can do more. And it has a whole lot to do with how that person feels that others care for them, their own self-care, and moving forward on that. We've already talked about screening for Matt and Katie, so I'm going to let that go at this moment and just say, do we have questions or comments from people?
Thank you, Dr. Guthrie. That was, I think that the combination of what you presented and what Katie presented sort of melded just so well. And I felt like you were channeling Abraham Maslow. 80 years ago, Maslow talked about not looking at our patients like a bucket of symptoms. And I think that what you described is sort of being able to, we always talk about that term or use that term, meeting patients where they are, but sometimes I don't think we really understand what that means. And I think you encapsulated that today, is understanding that we do a lot of difficult work. We, and I'm talking about us as providers, work with the most difficult patients that exist. We save individuals' lives, their families, and the community. And I know that as a group, we don't get that much credit for it. But I think that how you described sort of your approach to doing this would not only help the patients and the individuals, but I think it would help us as well in terms of being able to maintain our own sanity, look after ourselves, and be able to take care of ourselves so that we can continue to do this work. And I want to thank you very much for that. And let's open it up for, we do have time for questions. Let's open it up for questions.
I have a question. Katie Bell here.
Katie.
That was wonderful. Thank you, Libby. One of the biggest challenges in MAT is that complete integration of behavioral health. And you just did a really beautiful job on presenting it. But if you were making some recommendations about cross-training behavioral health therapists or clinicians into addictions, which is often the barrier, there's a lack of training. Do you have any approaches that you like or would suggest?
Well, Unfortunately, we still don't have a lot of, I mean, I may be wrong about this, but as little as 4 or 5 years ago, I did not see co-occurring disorders as part of programs for, when I did my doctorate, co-occurring disorders wasn't even a thing. I mean, it was interesting because I went through that entire program.
Did we lose Dr. Guthrie? Katie, are you there?
I'm here.
Okay.
I'm here. I think we did.
I think we lost Dr. Guthrie there for a second.
Okay, yeah.
Okay.
So, and do you have any thoughts, Al, about how to, the cross training of behavioral of, so I think Libby's back in.
Okay.
But I'm always asking that as we build MAT programs, that whole person care, often there's a gap in the behavioral health training.
Do you want, Dr. Guthrie, do you want to answer that question? Katie can probably repeat it.
Oh,
Yeah, it was about training.
Possible trainings. I know that Mendocino County Behavioral Health Services about 3 or 4 years back had a team from UCLA come up and actually train. However, it was only 8 hours or something like that. I mean, we need much more extensive training.
Was that Al?
I appreciated it.
Yeah.
I certainly did, because it at least brought the awareness that people need to be finding out more about their counterparts, if you will, who are doing substance use treatment, and they need to be finding out more about what we're doing. But we need more courses. And I used to teach co-occurring disorders at the local college, but I mean, we have to be spending time really talking about the bidirectionality of it, the way that it is so integral to that. I mean, it's like I said, 80% of our clients have both of those disorders on board. And even those that come into the syringe exchange, maybe not as, I mean, some of our clients come directly to us from that syringe services. But I don't have any quick answers other than doing research on your own, because we don't have a system that is set up even, you know, nationally. We talk about it, and we've been talking about it for 20 years. And I still don't see it as a requirement in both of those fields to know a great deal about the other person's field and how to treat this person collaboratively. I mean, case conferences are one thing, but again, I think case conferences are a report on what I did and what she did and what that person did. And instead of having a client plan that really does show all those needs, and how we're not just going to take pieces of those needs, but we're going to work together on those needs. And I don't have a better answer than that. So.
That's good.
Thank you, Libby. You know, Ben Anderson, it says at MCHC, we have integrated behavioral health as part of our MAT program, and much of the training happens on the job due to the lack of availability of formal trainings. So, you know, I think that what I've seen from the FQHCs who have embedded behavioral health and substance use care as part of their systems, we're seeing more and more of that occur. At least, you know, within California, and we're also seeing that, some of that occur nationally. So it
No,
is.
and I hear, and Ben's correct. Ben, I mean, they've had it integrated through their program for a very long time, but they've also throughout the years had to deal with the challenges of insurance companies and who was going to pay for what. And if you got the behavioral health care, who was going to pay for the meds? I mean, that's an old situation that is changing dramatically, and I'm very happy to hear that. But the actual training outside of those clinic, outside of that clinic is still very lacking as far as I'm concerned.
And Libby, there are this systematic and institutional barriers. We trained the whole Department of Mental Health Services within Los Angeles County on co-occurring disorders. The challenge that they ran into was exactly what you mentioned, and that is they're not licensed to provide substance use care, disorder care, and to be able to bill for it. And so,
right.
So those were some challenges that are within the system that those are some barriers we need to overcome, certainly.
Absolutely.
Other questions?
You're absolutely right. And sorry.
No.
Oh, was there another question you said?
Let's see. I don't see any hands up.
No. I think part of our approach at McCavan with our new low barrier MAP program is also including someone with an MHRS that, and as Ben stated, a lot of ours is going to be on the job, but we're lucky because we have Dr. Guthrie to lead our charge. But that's going to be part of our integrated approach at McCavan as well with our low barrier MAP program.
Yeah, we are going to have a rehab specialist and a clinic coordinator, and it will be very low barrier. And we're just actually looking at the protocols right now, how we're going to manage this new situation. Mm-hmm. Several places in California just got those low barrier MAT access at syringe service program grants. And we literally just got it last week. So we're going to be working on how to serve individuals who are coming into our syringe exchange and are tired and or just, this is it. This is it. Yeah. So
congratulations on that. That's wonderful.
Thank you.
So we've come to the end of the presentations. I want to thank Katie and Dr. Guthrie for their thoughtful and enlightening presentations, and also Grace and Dr. Guthrie for forging on even with all the technical challenges that you have. I'm going to go ahead and turn it over to Buffy at this point in time, and she's going to go over our survey results.
Oh, that was a surprise.
Oh, did I surprise you?
I don't have capabilities to share my screen.
Here, I can do it, Buffy. I'll share.
Sorry, Buffy. Did I throw you under the bus there?
You did.
Oh my goodness.
Way to go, Al.
Al gets the gold star of the day, though.
He really does.
I mean, he's been
That's right.
He stepped up to the plate.
Thank God for Al.
Right. This is more of Katie's anonymous stigma survey. I just played the background role of making sure to get it together for us.
Beautiful.
Yeah. So Katie, take it away.
I don't think I can scroll it from here.
No, Grace will have to
just tell.
Yeah, Grace can do that.
Yeah. So
let's do a couple of questions. I know we're out of time, but I just for interest here. The first question was, although I don't necessarily agree with them, sometimes I have prejudiced feelings like gut reactions or spontaneous thoughts towards drug users that I don't feel I can prevent. So that's like that visceral response. And the highest number was 40% agreed. And you can see the variables here of agree, strongly agree, and disagree, and strongly disagree. Let's look at the other, another one. I understand the experience of being stigmatized as a drug user. Strong agreement in this crowd, which we would expect. Let's look at strongly disagree. There were some people that strongly disagree to the statement, I understand the experience of being stigmatized as a drug user. So this has got some interesting reflection here. Let's just do one more. Let's scroll down into the next. Ooh, look at that one.
Wow, it's even.
It is. So here's a good one. It is not appropriate for me to talk about my drug and alcohol use with clients. So this is agree and disagree very strongly. Nobody strongly agreed with that statement, but the agree disagree was equally strong. So this is about those of us that have some lived experience as recovering people, and the appropriateness of introducing that topic. This could be a whole session.
Yeah.
And Tony Marsh said it is completely situational, which is exactly right.
It's contextual. When is it appropriate and when is it absolutely not? And you got to make those calls.
Yeah. There's a lot of discussion around this, but it is always, you always have to go to the situation. Let's go to the last one. Do we have time for one more?
Yeah, we've got another 11 minutes.
Oh, if a woman is pregnant, she has a responsibility to stop taking drugs. So this goes back to Tim's comments and Andrea's comments, and about our case, Allie, who has just found out that she's pregnant. And here's our response. If a woman is pregnant, she has responsibility to stop taking drugs. Any thoughts?
I think maybe I'm a little shocked, but I shouldn't be because we work in harm reduction here, so that's not an uncommon thing for us to be treating pregnant women and helping them be safe as they can be. That's always our goal. So
because we are an anonymous exchange program, we during that anonymous activity, we do not get involved. We're not. We just want people to be safe. We may even talk to them about the safety for themselves and the baby, but there isn't going to be.
There's no judgment or no discussion about stopping.
And it is hard. It's very hard. Over the years, certain things have happened that have been extremely difficult. It's often really good if you can talk with somebody about their fears. And
I think often when we do see pregnant women come into our exchange, for example, we are able to, because they're not getting judged, because we're not doing anything but offering supportive resources and safe use, I think that they're more inclined to come back and ask us for the help that they need, because they aren't stigmatized and we do treat them with anonymity and respect and care and dignity. Buffy has her hand up.
Buffy has her hand up. I have a thought too. Go
Yeah.
ahead, Buffy.
Yeah, so the thing about this is if you're working in harm reduction, I can totally see why we're so progressive in the way that we treat pregnant women. But as a culture and just looking at society at large, it's always been expected that the woman does something different and that she has the ability to do that. And I think that's why so many people agree that she has the responsibility. It's not something that's just going to go away because we came to this training. It's like this whole thought process around it has to happen, and a shift in the way that we look at pregnant women. And that's kind of how, because I've listened to a lot of people over the years and still to this day, and that shift just hasn't happened yet in this area, is what I see.
Thank you. Andrea, you have a thought. I'd love to hear it.
I was just thinking, I think a lot of us were probably thinking we would love to see a pregnant woman stop using drugs. That's kind of how I looked at it. So defining what's the patient's responsibility, I think gets a little murky, but I feel like we would love to see that happen is kind of, the first thought.
Yeah, I love how that we have a strongly agree and a disagree that are almost the same. It's almost, in some ways, the answer is yes and no. In that expectation that she will be responsible. But those of us that have worked with a lot of pregnant women, we know that is some of the greatest motivation we're going to encounter is when a woman is pregnant and she begins to have concerns for her baby. Many doors to recovery open that are that before would have been closed. Yeah. And if a doctor, the one who said CPS is going to take your baby, if there would be a whole other way of talking about that. It doesn't have to not be discussed. How do you feel about being pregnant? What are your concerns? Would be completely different than walking in with a threat. So has to be part of the conversation. Okay, Andrea.
Another interesting side question is last I heard, I'm not sure there are specific MAT resources for pregnant women in Mendocino County. Is that right? Does anybody know?
Our Care for Her program does have, at MCHC, does have an MAT provider.
Shall we do one more question?
Sure, we have time.
Okay. Okay, let's do this one. I trust drug users just as much as I trust non-drug users. This is a tough question. And you can see that more than 60% of the participants said they disagree. Any thoughts?
I did. Am I on?
Yeah, you're on.
I am. I was going to say I did. I disagreed because I even though I know, as far as, I guess because I've been around drug addicts so much of my life, I know what to expect. I've been stolen from many a time from somebody not using drugs. I don't necessarily, I think for a lot of drug addicts, stealing or whatever, lying is a part of that. But I've been really surprised to find out people that aren't on drugs, it can be just that much a part of their lives too. So I don't want to be gullible and think just because somebody's not using drugs that they're trustworthy.
Very interesting.
I agree with that, Debbie. I also think with a lot of the folks we see at McCavan, their survival skills have taught them to, like, the way they live on the street, the way they have to survive, the way they have to find a way to feed themselves, often is through theft, because they're trying to stay alive. And so as a provider, I don't feel like I distrust. Obviously, I'm not, we have to protect records and all those kinds of things, but I try to open up that trust for those folks, because I look at it not as a way to shame, but as a way to, this is how you survived, and what are some resources that we can help you so you can feed yourself. I mean, it sometimes is that basic. So if you dig a little bit deeper to see why somebody has been living that way for so long, I think people would be surprised. I think it's easy to think just because someone's using drugs means they're a criminal, and I don't believe that at all. So
I don't either. That's a good point. I never took it to that place. That's why when I first said that, I think to know what's expected from somebody that's living on the street, not that it's good or bad, and it's not about judgment, it's just to know and to not be naive. Just because somebody doesn't use drugs doesn't make them a good person.
Right. Also, for us at McCavan with our clients, I would say, we meet you where you're at, if you're actively using or not. And the way we work is unconditional positive regard, but also, we don't treat your behavior and your substance use as necessarily one. So you can be a substance user and still come in the door. And if, you're respectful, there's no threats, anything like that. We don't lump it all together. So that's just my thought. Oh, Libby's back. So we're talking about trusting drug users just as much as trusting non-drug users. And I was talking about often our clients learned those skills on the street and how to survive in their life. So I'm done now. Sorry.
That's okay.
This is Marianne. I was just going to mention or comment. I think it's hard to answer these questions because the way they're presented is somewhat simplified, and they're so much more complex. Even the piece about the responsibility of the pregnant woman, and then this piece about, do you trust drug users? These are not simple answers. And so it's hard to take a survey like this and to feel like you're being entirely fair. So I just wanted to say.
Yeah, I agree with you. I keep wanting to rewrite these questions, but I think, I agree with you, Marianne. It's hard to give an answer here. Some of these questions.
Katie and Marianne, I hope that's your name, but I think your point is so well taken that it causes us, and I think the whole premise here is to cause us to look and evaluate ourselves as it relates to stigma and how we treat individuals in the community who have that perceived threat based upon being a drug user versus the rest of society. And I think that Debbie brought it out so well, is that, look, you're just as likely to get robbed or mugged or whatever the case from somebody who doesn't use substances as you might be from somebody who does. And so I appreciate the conversation and the thought, the thoughtful presentations, the thoughtful discussion that everybody brought to this today. Don't forget that next week, a week from today, we have Dr. Greenberg who'll be presenting. And I want to thank everybody for the service that you provide and for the time that you've allocated to be present today. Thank you all very much.
Thanks, everybody.
Bye.
Thanks. Bye-bye.
Thank you. Bye.
Bye, everyone. Sometimes,